So with that, we're going to introduce our speaker this morning. Dr. Emergencies is a specialist in occupational medicine, currently appointed as the head of occupational medicine at Tygerberg Hospital and as a senior lecturer at Stellenbosch University. He started his career in the military looking after the SA Navy divers, and from there developed academic training programs in dive medicine at Stellenbosch. These programs were subsequently accredited internationally. He is an internationally recognized expert in dive medicine and is the medical director for the DAN Network, Divers Alert Network of Southern Africa. He's also a consultant for DAN Europe and DAN America, as well as DAN World. He serves on various national and international committees, guideline policies, and legislation in the diving medicine field. We are very privileged to host Dr. Menkes this morning.
Thank you, Caleb. Thanks for having me and the opportunity to share the introduction to diving medicine. Let me just get my presentation started. Do you prefer my video to be shared, or do you want my video to be stopped there?
Completely up to you.
Okay, I'm happy to have it shared. That's fine with me. Let me just swap this around so that you can see the presentation there. Okay, so I've been asked to do an introduction to diving medicine. Why? Why do I need to talk about this? Well, 70% of the Earth's surface is covered by water. We are the blue planet. And more and more we see a move towards the watery environment. We see mining activities, sporting activities, even farming activities in terms of fish farming, kelp farming, etc. So work, recreation, all of that we see more and more towards the watery environment. If you look at South Africa, approximately if you look at our land mass, the surface area of South Africa compared to our area covered by water, it's double. And so the government has actually, in the past number of years, looked towards the expansion of what's called our blue economy. And you can search this on the internet. You can look at Operation Pakisa is the specific program where this is being developed. Now I'm going to talk about the people that work in the underwater environment, so specifically diving, and of course there you get people that just do it for fun and people that do it in their working environment. So recreational divers versus the commercial divers. Now, recreational divers, of course, they like to dive when the sea is flat. And the reason, obviously, is because we want to go and look at these beautiful creatures. And it's really like being in outer space. You're floating around, you're weightless, you don't know the animals, you don't know the plants, and it's really an exploration. And you sound like a spaceman, you know. So I mean, and if you just look at these pictures, some of these reefs are really beautiful. Obviously, not here where we are in Cape Town, closer to the Durban coast, it gets a bit better. But because it's not always like this in Cape Town, we get to travel a lot as well, which is always nice. On the commercial side, obviously, it's a lot different. The diving is not because of the beauty, but because of work and because of employment and specific tasks that needs to be done, whether it is construction work or maintenance work or, well, anything really that you can think of doing it above water. You can do exactly the same job underwater. Diving is not the job. Diving just gets you to the job and to the workplace, and then you do the job when you are there. For instance, when you look at the diamond miners on our west coast, this would be what it looks like. So nothing glamorous about that. No great viz, no beautiful things to see, except if you get a beautiful translucent rock, which is something that my wife gets to like a lot. She's like a crow, you know. The more something shines, the more. Yes, you complete the rest of that sentence. Or a policeman. They are like pigs in sewage, and looking for evidence or bodies or whatever has been dumped in there, and they need to get the evidence out of there, and so then it might be zero visibility that they are diving in, and so there might be other emergency type situations that they may find themselves in. So it's really a wide range of emergencies that one might be able to deal with. So it's not possible for me to cover the whole range of things that divers can get themselves into. I'm just going to cherry pick a few selected conditions that divers can present with. Now, before we can get into the conditions that I am going to cover, we just need to cover some physics, unfortunately, and I don't know whether you feel like me about physics when I need to go back to grade 10 or grade 7 or grade whatever it is, which for me is a long time ago. But let me try and dummy it down to a level where I can understand it, and hopefully it'll make sense for you as well. And the first one would be Dalton's law. And Dalton's law says blah, 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 and I can't understand what it says. So I remember it by this picture. It says if you've got a mixture of gases, the total pressure of this mixture of gases is equal to the sum of the total pressures making up this mix. And you can see this in the picture, but in diving medicine, we actually work this law from the other end. So we don't say the sum of the partial pressures will make up the total pressure. We actually say, let's go diving, let's increase the total pressure. In other words, let's increase this side of the equation. Now, once you increase this side of the equation, automatically all of these partial pressures are going to increase. So you haven't done anything really. You've just increased the pressure. You've just going deeper, and the partial pressure of carbon dioxide in your lungs, that's rising. The partial pressure of oxygen is higher. The partial pressure of nitrogen is higher. So all the gases that you are breathing, those partial pressures are going to increase simply because you are there. You don't need to do anything. Just because you are diving, the total pressure increases, and therefore the partial pressure is going to increase. That's Dalton's law. And so I hope this picture makes sense to you. The next law is Henry's law. And again, it says a lot of words there, but for me, the picture says if you increase the partial pressure, just like we said now, Dalton's law says it would, Henry's laws say, well, if you increase the partial pressure of a gas that's in contact with the liquid, then more of this gas will dissolve into a liquid. And if you decrease the partial pressure, that gas will come out of solution. But I mean, this is something that we've known all the time. So with fizzy drinks, for instance, if you increase the partial pressure of carbon dioxide that's in contact with water, we make carbonated water. And if you open up the cap, so if you decrease the partial pressure, then that gas will come out of solution and the Coke is flat. Now, exactly the same with the diver. If you go diving and you increase the partial pressure of these gases, those gases will dissolve into the diver. And when you decrease the pressure, so when they come out after a dive, then that gas will come out of solution. So the diver becomes a fizzy drink. That's basically what happens. And so you know what happens when you shake a fizzy drink, and you know what happens when you open up a fizzy drink too quickly. The fizzy drink gets decompression sickness. And that's what it is. And divers get decompression sickness. So what is decompression sickness? It's that the diver is exposed to these gases, and we specifically look at the inert gases here. So they are exposed to the inert gas at pressure, which means, in accordance with Henry's law, they are now going to dissolve this inert gas into their bodies. And then you reduce the environmental pressure. In other words, you open up that can of Coke. And with decompression, that is going to ensure then with Henry's law that the gas wants to come out of solution. But you know that if you've got a Coke that forms a lot of bubbles, you are not going to just open it, because then your Coke is going to bubble over. You're going to open it slowly. So, and the same with divers. They need to, and we call those decompression stops. So if your rate of pressure change is too high, in other words, if you come up too fast, then you are going to form bubbles. And those bubbles can then cause symptoms. And that whole clinical presentation of bubbles forming in the body of a diver, we call that decompression sickness. So here we've got the diver. The diver is at depth. Because of the increase in total pressure at depth, the partial pressure of all the gases they are breathing is increased. You will see that on the back of the diver, they are carrying gases in a cylinder, and the gases in the cylinder normally is not an oxygen cylinder, but it's a cylinder of compressed air. And this is air. 80% of the air that we breathe is nitrogen, 20% oxygen, and then some other gases, carbon dioxide, etc., etc. But 80% is nitrogen. And Henry's law says if you then increase the partial pressure of nitrogen, more of the nitrogen is going to dissolve in the body of a diver. So let's just go through it one more time. I've got the diver. The diver is compressing, going deeper, and that means the partial pressure of nitrogen is going to increase. Now, depending on the depth, so let's say, for instance, they go to 5 atmospheres of pressure equivalent, the depth and the time that they spend there, the longer time they spend, the more gas they're going to absorb. And if they now end the dive and they start decompressing, they are then going to decrease the partial pressure of the gas. And that means that the gas would want to come out of solution. Now, this is the important component, the decompressing component, because if they open up the bottle slowly, you remember from opening up a Coke or opening up a bottle of champagne or whatever, you can see this white smoke coming out. This is carbon dioxide vapor. If you open up that bottle slowly, the gas comes out in a gaseous form where the diver can then exhale it and that it wouldn't cause any symptoms. But take exactly the same bottle, open it up too fast, and it actually forms bubbles. So if you decrease the pressure too fast, you form bubbles, and those bubbles can then cause symptoms. So let's just have a look at a quick video just explaining it one more time.
With a vacuum pump and a beaker of water, we can dramatically relate Henry's law to decompression sickness. The water in the beaker is saturated with air at ambient pressure, much like a diver who becomes saturated at depth. When the vacuum pump is turned on, the pressure on the water drops, much like the pressure change as a diver ascends towards the surface. As the pressure drops, bubbles seemingly begin to form out of nowhere. As the pressure in the jar continues to fall, the saturated air continues to come out of solution. If this were a diver, decompression sickness would result. Using the same process, watch how gelatin, a substance similar to tissue, reacts to the fall in ambient pressure. Bubbles grow in the gelatin as the pressure continues to fall. If the vacuum pump is turned off and the pressure restored, such as in recompression, the bubbles instantly disappear as the gas redissolves into the gelatin.
Okay, so there you can see with recompression, the opposite will obviously happen. So what happens if you get all these bubbles? Well, the bubbles can cause an obstruction or embolization if it's in the vasculature with distal hypoxia. Or if you have a bubble forming in tissue, like in the brain or in a neuron or in bone or somewhere, it can have a local pressure effect on the tissues. If it travels in the vasculature, it can strip the endothelium, and therefore it results in fluid moving into the extravascular space, causing increased permeability, swelling, edema, etc. And the bubbles are actually not innocuous. Our body reacts to the bubbles. So you activate the inflammatory cascade, the complement cascade, the clotting cascade, and so forth. So those of you who are divers in the group can attest to the fact that after a dive, people normally are quite sleepy and tired, etc. That's because of this inflammatory cascade that the body actually reacts to bubbles that are forming, and therefore you have these effects after a dive. So what is decompression sickness? It's this whole syndrome. It's characterized by symptoms that are the effects caused by the formation of the bubbles, as well as our body's reaction to these bubbles. That's decompression sickness. So let's get into how the patients present. What would be the symptoms of a person presenting with decompression sickness? And I can hear how the people are shouting out all the symptoms. They're all muted, but yes, you're correct. Whatever you said, you're correct. Because it depends on where the bubbles are. You can say any symptom you want. If it's in Broca's area in the brain, you won't be able to speak. If it's somewhere in the spinal cord, you might have weakness or tingling or numbness in that area. If it's somewhere in the bone, you can have joint pain or pain in that area of the bone, or any symptom really after you've dived could be decompression sickness. Because the bubbles can form in that area of the body. If it forms in the heart, you can have symptoms related to the cardiovascular system or the cardiac symptoms and so forth. So that's decompression sickness. Let's quickly talk about barotrauma. Barotrauma is related to Boyle's law. And Boyle's law basically says that if you keep the temperature constant, then the volume of a gas is inversely proportional to the absolute pressure. So if you take a balloon and you increase the pressure, that balloon will shrink in volume. And if you decrease the pressure, that balloon will expand. So here you can see it with depth. If you're at the surface, that's 0 meters depth. 10, 20, 30, 40 meters. And when you are at sea level, 0 meters depth, the pressure is 1 atmosphere. For every 10 meters depth in the water, you actually add another atmosphere of pressure. But just look at the volume here. So double the pressure, 2 atmospheres, half the volume, 3 a third, 4 a quarter, 5 a fifth. So you can see the inverse relationship between pressure and volume. But interestingly, if you put this on a bar graph, you will see that if and on the x-axis here, you can see depth 0, 10, 20, 30, 40, 50, 60, and the pressure 1, 2, 3, 4, 5, 6 atmospheres. If you change depth with 10 meters, so I ascend from 80 meters to 90 meters, 9 to 8 atmospheres. Just look at the change in volume, the blue bar graphs here. The change in volume is really very, very small, but just change depth of 10 meters close to the surface. So from 10 meters to the surface, the pressure doubles. So you can see that in terms of barotrauma, the closer you get to the surface, the greater the pressure change. It's actually easier to change depth when you are deep than it is to do it close to the surface. And that change in volume can affect anything in your body that looks like a balloon. So sinuses and sinus barotrauma. So let me show you a few case studies. This is a CT scan of a diver that went diving. And when he descended, he had a bit of difficulty equalizing his ears because he had a little bit of a congestion in the sinuses and the ears, a bit of flu, etc. But managed to equalize, etc. And when he started ascending afterwards, the gases then started expanding and expanding. And then he had quite a bit of pain in his maxillary sinus. And then he heard this cracking noise in his skull, which, as you know, that's never a good sign. And you can see here the fluid level in the right maxillary sinus with the fracture of the infraorbital plate. There's the gas space in the maxillary sinus. This is now not draining the air as it expands. And as this person continued to ascend to the surface, he actually developed proptosis. As the air then and all the muck and things then escaped through the orbit of the eye, and then had some problems with his eye, obviously. And that is one of the complications then of sinus barotrauma that this person has suffered. The ears, I mean, we all know if you drive over a mountain or you fly in an aircraft, etc., that your ears block up. And that's because of middle ear volume changes with changes in pressure. So this middle ear space with the link via the eustachian tube that opens up in the torus tubarius in the nasopharynx, giving you this air space that needs to be equalized. So when we examine divers, we actually look in their ears, and this is a video otoscope. So you look in the diver's ear and you ask them to equalize their ear. So you ask them to push air into the middle ear space, and we say, equalize for me. And then you can see the movement of the tympanic membrane. Just equalize again. And there you can see the movement. And that's what a diver must be able to do in order to be able to dive safely and obviously to fly and so on as well. Now, if you are not able to do that, you will suffer middle ear barotrauma. And here is exactly such a case. So you can see the whole middle ear space is now filled with blood and fluid. You can see the bubbles in the middle ear space. And so this would be Teed scale 4 middle ear barotrauma that this individual has suffered, who had difficulty equalizing their right ear during a dive. Equipment can also cause barotrauma. So if you dive in a dry suit, and this is now a suit that is now compressed with gas. So you can see the suit here, and this suit is now being, the volume increases and decreases, and you can see how the suit now bit this person on his shoulder because of the increase and decrease in pressure. And cause some suit squeeze is what we refer to here. This is me in the harbor in Durban a few years ago, and I've got a gas space in front of my face. This gas space needs to be equalized. So as you descend down in the water column, this volume of gas will decrease. And so it feels like the helmet or the diving mask sucks onto your face. And if you don't equalize that gas space, then you will get mask squeeze. So this is a case that I actually treated last week of a diver that suffered mask squeeze. There are some more severe cases described in the literature, and here you can see such a case that we've treated as well of mask squeeze. And all masks will then include the nose. If you dive with swimming goggles and you think that you're a tough Navy diver, diving to 30 meters with swimming goggles, you will look like an alien. And here is exactly such a case. Now let's get to the biggest balloon in the body, and that's the lungs. So pulmonary barotrauma. So pulmonary barotrauma obviously is our biggest concern. And let me just walk you through this. So I've got this diver. She's now diving at 10 meters depth. She's going to ascend to the surface, and if her lungs contain 5 liters of air, she needs to exhale 5 liters as she ascends to the surface. And if she exhales 5 liters, she will still have 5 liters left, because the 5 liters will double to 10 liters. But let's say that she starts with this ascent, but there's a blockage because she's got an obstructive defect, so COPD, emphysema, asthma, or there's a restrictive defect, so scarring in the lungs because of TB, or she's got a lung disease in the lungs. What will happen if she ascends and she cannot exhale the gas as it expands? What happens to the lungs if you just keep on expanding this balloon? That's what's going to happen. So pulmonary barotrauma.
A vacuum pump and balloons can demonstrate Boyle's law. A balloon is placed under a vacuum jar, and the pump lowers the air pressure. As the pressure lowers, the balloon grows. Its volume increases according to Boyle's law. When the vacuum is removed from the jar, the pressure quickly rises, returning to ambient pressure. The balloon also returns to its original size and volume. Suppose this red balloon represents the lungs of a diver. Like a diver ascending too quickly, holding his breath, the surrounding pressure on his lungs decreases significantly, while the pressure inside his lungs increases. This would cause his lungs to expand rapidly. If the pressure differential is great enough, a diver could experience lung rupture. This can occur with as little as 1 meter or 3 feet of depth change.
Sorry, I didn't get that last part. What did she say? 1 meter? That's the shallow end of a swimming pool. The shallow end of a swimming pool, and you're dead. That is scary. That's seriously scary. And if you've got predisposing factors, we're talking about asthma, COPD, fibrosis, bulla in the lung, people that can also get spontaneous pneumothoraces and so forth, sarcoidosis, scarring, etc. That is seriously scary. In fact, it's actually not 1 meter. It is less than 1 meter. It's been well described, and this is just one of many such publications. 0.75 meters or less. So any person who takes a breath of compressed gas from any source at depth is at risk. So let me just give you some examples. Submarine escape training here close to us in Simonstown. You can see the picture on the right-hand side here. This is the submarine escape training tank. These guys fly through the water with these suits that pulls them through the surface. If you're scuba diving, but even if you just take a vehicle and you drive into a body of water, the vehicle starts sinking, which means the air in that vehicle is being compressed. You take a breath from that air, you open the door, and you stand up in water that is less than a meter deep, and you are dead. It's scary. If you stand up in water that is more than a meter deep, you have to exhale if you've taken a breath of compressed gas. Let me just show you what the expansion looks like. So this is the submarine escape training tank. So the people are in the submarine simulator at depth. You can see they get into this little capsule where the water then rushes in, which means that the air in there is compressed. And then the guys have to scream all the way to the surface, just, "Wah!" And we do the standby at the surface. And then if they don't scream, then we know that they're not exhaling enough. And then there's a real risk that they can get pulmonary barotrauma and be seriously ill. In the UK, we did some trials in the ocean from 90 meters, 90 meters. And this is what it looks like. So when they are at about 75 meters or so, just look at the gas expansion and how rapidly these guys are going, screaming. Ah! So you can just see the gas coming out there. What does it look like closer to the surface? Look at the gas expansion. And you can see why, if this guy is not going to scream, he will literally explode as the gas is expanding. The barotrauma, you cannot survive this. You have to exhale on the way to the surface. When these guys come out at the surface, they look like a rocket. They pop out the surface, and then we are at the surface, and just pray that these guys are alive. It's really a phenomenal medical standby when you're in the military doing this. Here's the diver. The diver takes a breath of compressed gas, and as this diver comes to the surface, they need to exhale. They need to exhale the compressed gas that they breathe at the depth, so that they don't get pulmonary barotrauma. Can this person get pulmonary barotrauma? And the answer is no, you cannot. And if you just look at me, you can see that the person has taken a breath of compressed gas. They dive deeper, and then they come back to the surface. So they come back to normal. Who's the person that's going to get barotrauma? It's the person that dives down, and then they take a breath of compressed gas at depth, and then they want to come back to the surface. So you can see that even if you dive into the deep end of the swimming pool, you are fine, as long as you don't take a breath of compressed gas at depth. So you can dive into the deep end, you are fine, but the child inverting a bucket in the swimming pool in the shallow end and breathing inside the bucket and then standing up, that is a risk. So how many of you are lucky to be alive today with me? Because we all try to breathe from that bucket in the swimming pool, isn't it? Yes. Yes, Corinne, I see your hand there. Yeah. So many of us have done this, and we are we are lucky to be alive because we've taken that breath of compressed gas at depth. Here you can see an example. This is pulmonary barotrauma in a free diver, but they've taken a breath of compressed gas at depth. So you can see the diver here. The diver is breathing the compressed gas, but look at this octo rig. So you can see the octo coming to the diver. He's taking a breath of compressed gas at depth. This is the last photo of him alive. The bubbles you see here is coming from the diver down below. He did not exhale on the way to the surface. Resuscitation was for about 45 minutes at the surface. He was declared dead on scene. Real case. I'm not making this up. So let me show you what happens here in this case. You have the alveolus that ruptures. So the gas just keeps on expanding and the alveolus is going to rupture and you get pulmonary interstitial emphysema. So the gas is now going to track in the tissue of the lungs, and this can cause mediastinal emphysema. If this expands and tracks down the aorta into the abdominal area, you can get a pneumoperitoneum. It can track upwards with the aorta, and you get subcutaneous surgical emphysema when you examine the individual. It can cause a pneumothorax. And what happens if you've got a pneumothorax and you ascend further? You need to come to the surface. That pneumothorax is going to expand and cause a tension pneumothorax. So you can see all these things that are in black down here. These are the things that can happen to the gas as the lung expands and the alveolus rupture. So interstitial emphysema, pneumothoraces, and so on and so forth. This is a case that we treated here at Tygerberg Hospital, I think about 3-4 months ago. He dived in one of the towns in the area. I'm not going to give you a lot of details here. He was diving on hookah, and then the air supply was cut for some other reason, and he had a rapid ascent to the surface. But here you can see this is the lateral C-spine. But just have a look at the air tracking between the soft tissues, and you can see here, it tracks all the way almost to the base of the skull here. You can also see under the skin how the air is tracking over here in the soft tissues. I've got a CT scan also here, and I hope that it presents fairly well. So let me try and play the video of how we did the CT scan, and that you just see. You will see this is going from superior to inferior, and then you will see that there are pneumothoraces. Have a look at anterior at the top here, how the air is there, but also between the muscle layers at the back. How the air is tracking there all the way in there. So here we go from the top to the bottom. You will see there the lungs are coming. Can you see on the right hand side of the screen the lungs with the pneumothorax? So air in there. I'm going to play a little bit further. You can see on the left-hand side of the screen some air between the thorax and the pec major. There's some gas in there. And as we carry on, you can see the gas between the muscle layers on the left-hand side and under the skin and the tissues there. As we go further down, you can see the air there around the heart. You can see the pneumothorax and the pneumomediastinum that the person has got there. But then you can also see at the bottom, even under the scapula and the muscle layers there, subcutaneous emphysema as this person has suffered there. And you can see even here some gas in the under the tissues around this person's back. So these are some of the complications that you can get from pulmonary barotrauma. This is an hemoperitoneum. You can see all the organs, etc., but the whole abdomen is severely distended with gas filled in the peritoneal space. But that's not the only problem. You can also get arterial gas embolism if the alveolus ruptures. And remember what your alveolus look like. It's surrounded by blood vessels for gas exchange. And if you rupture the alveolus, you can have bubbles, the gas now entering the circulation. And if it enters the circulation, it's then suddenly on the wrong side of the heart. Because, I mean, we all know the right side is the right side. The left side is the wrong side, because if it's in the left side, it's going to be pumped systemically. And especially if it goes to the heart or it goes to the brain, you're going to have a problem. So here are a few CT scans again. You can see on this CT scan here some gas embolisms. These were non-fatal cases. Here you can see a fatal case with severe gas embolism. Circle of Willis and et cetera, et cetera. This is an autopsy case that Professor Knobel and I did a few years ago of a Parliament poacher here in Cape Town. You can see, just to orientate you, this is the vertebrobasilar artery. That's the circle of Willis at the top there. And you can see the gas embolism in this case specifically. Here you can see what the diver's lungs look like, and you can see just the expansion here, the bullae as the injury occurred in that particular diver. Again, what are the symptoms? Well, where did the bubbles go? Wherever the bubbles go, that's where you're going to have symptoms. So just remember, it's not a bubble; it's a shower of bubbles. It goes to multiple sites. And it's being pumped by the left ventricle everywhere. So you get a stroke and a heart attack and a kidney attack and a muscle attack and everything at once. Just look at this brain. You can see all the splinter hemorrhages of where the bubbles went. It goes everywhere. And so let me just stop there for a moment. Those are just two of the diving related illnesses that a person can get: decompression sickness, barotrauma. And so the question then, I think, for the interest of this group is, how do we treat it? These conditions, if we group all of them together, bubbles in a diver, whether it's gas embolism or decompression sickness, we don't care.
It's very easy to understand, yeah.
Sorry. So we don't care. Sorry, there's somebody who's not muted. So we don't care where the bubbles come from, as long as they are bubbles. So what would be the pre-hospital management? And I've got a reference there for you, which is a very useful document for you who are interested in the pre-hospital management. So this is an expert review, and the key principles and the controversies. I'm just going to quickly go through this. So obviously a person needs to recognize the symptoms, resuscitate, but it's oxygen and fluids. Those are the two main components, oxygen and fluids. And then we get them to a chamber. One needs to look at the emergency treatment, of course, because you often need to deal with things like near drowning, etc., because sometimes divers will do some crazy things as part of the rescue. And how long does it take them to get the diver to a place of safety? So sometimes there could be marine life injuries associated with this as well, and so forth. There could be a long delay before they get an unconscious person in a dive boat and so forth. But once you get the person to a stable platform, so whether that's the shoreline or in the boat, then it's easy. All the roads lead to oxygen. Oxygen, oxygen, oxygen. And to give oxygen, we want to get close to 100% as possible. So we don't want to give a Hudson mask or a normal oxygen mask. We want a non-rebreather mask. So that's the one with the valves, the reservoir, and it's high flow rates, 15 liters a minute. Or you can use a demand valve or a bag valve mask with a reservoir. Or if the person has been diving with a rebreather, you can use a diving rebreather as well. In terms of positioning of a diver, they must be supine. Unless if they're unconscious, you can use the recovery position. If they're intubated, you can obviously keep them supine because then you've got the airway protected. Fluids, oral is okay if you've got a mild case. We give them non-carbonated, non-caffeinated, non-alcoholic isotonic fluids. In severe cases, it's IV or intraosseous fluids, non-glucose containing isotonic crystalloids. And normally it's a bolus, so 1 to 2 liters in the first hour that they need. There are some cases that requires many, many liters before their blood pressure stabilizes. And then you phone a friend. So Divers Alert Network has got a hotline that could guide you through the management. We can connect you with a diving doctor. There you can see just my details where we can connect you. We connect you to the HEMS people that can fly you to one of the chambers. So we keep a database. So these are the chambers that we've visited, and we look at the level of patient care that the chamber can provide. And then we send the person for recompression therapy in that chamber, and so forth. So I think I'm not sure whether there are any questions. Let me perhaps just stop there. Of course, there are many other conditions. I don't have the time to go through those. But with Divers Alert Network, people can contact us. You can also look at the Undersea and Hyperbaric Medical Association if there are some of you that are divers or interested in this field of medicine. Or if you want to contact me, you are also welcome to do so if you want more information. And that's all from my side. If there are any questions, thank you.
Tilani, you have your hand up. You're welcome to go ahead.
Hi, Dr. Menkis and everyone. I'm not sure if I'm audible, but I wanted to ask you, in terms of using CPAP, especially for those diving emergencies, as an immediate treatment for diving emergencies with those patients with the sustained pulmonary edema due to diving emergencies, do you think also that would help them benefit, especially in those acute phases before you even transport them to hyperbaric chambers?
So for immersion pulmonary edema, obviously yes. So for IPE, that is one of the mainstays of treatment. For pulmonary barotrauma, one has obviously to be careful in terms of your pressures, because if you have barotrauma and you then increase the pressures, then you might embolize a person further. So all ventilations, etc., must be done with care. So that you don't cause further barotrauma and embolize the person further. The oxygen would obviously help with off-gassing and getting rid of the inert gas. As you think, Henry's law says the amount of gas that you've dissolved is related to the partial pressure of that gas. So if you've got 100% oxygen, then there's no nitrogen. In other words, you can get oxygen into the diver, but the nitrogen will just come out of the system. And that's why we would give the person 100% oxygen, even if they are they've got good oxygen sats. We would still give them 100% oxygen so that we can get the nitrogen out of their system. But CPAP for immersion pulmonary edema, definitely, that's the main treatment for IPE, but we didn't cover that today.
Okay, thanks.
Morning, Dr. Menkes. It's Sue from MSO International. I just wanted to ask you mentioned something about the changes in pressure when you fly over a mountain. Is it the
Yes.
same effect that you have when you actually fly over a large body of water or you land close to a large body of water?
So any change in pressure would also affect the diver. So yes. So after a dive, if we have a diving injury, we can't just load them in a helicopter or an airplane and just ignore the changes in pressure. So those are quite exciting evacuations. It's low flying or in a pressurized aircraft. So the rule normally is we don't like to fly more than 300 meters, so 1,000 foot above injury altitude. So that's normally the rule. But of course, the pilots need to look at the safety of the aircraft and the team as well. So those would be the guidelines. And one would always look at that risk-benefit ratio. But that would be the guideline. There are specific tables that we also use to do some calculations in that regard. But altitude changes, or even if you dive here in Cape Town, there are some mountains around. So you need to drive around the coastline. You can't drive over a mountain to get to your next destination, because just driving over a mountain would also be a problem.
Thank you, sir.
Gerald, you can ask a question.
Good morning. I just want to find out, in terms of pain management, what is your drug of choice? Like, can morphine, is that safe for a patient, or like a person that has mild symptoms and you want to give pain relief, morphine, paracetamol, which one would you choose, or ketamine or fentanyl, or what is your choice of medication? Where do you start normally?
So in terms of pain associated with decompression sickness, I would always recommend that you stay in contact with the Divers Alert Network, because it's highly dependent on that specific case. Oftentimes we use pain to guide the treatment of the case. So the chamber treatment table might be dependent on the clinical presentation of the case. So, but as a typical guideline, the pain only bends if it's in a joint. We will typically go for an NSAID type treatment. So that would be something like Perfalgan or something like that. If you need something IV, we would typically not give the scheduled medications because of a few things in terms of the interaction with hyperbaric nitrogen. But in some cases, we might use those if there's a higher risk for oxygen toxicity in the chamber. So when you give high pressure of oxygen in the chamber, the person might have seizures. And so if you've given some of those medications, then they may interact with what we are going to give in the chamber to prevent the hyperoxic seizures. So it's important just to stay in contact with the receiving chamber when they're going to get hyperbaric oxygen therapy.
Brilliant. Thank you so much.
There's just some questions in the chat. I just want to go to it quickly.
Sure.
Okay. Someone wants to know if there's any hyperbaric chambers in Limpopo, or what would be the closest one.
So it's a difficult question to answer. Yes and no. So we keep tabs of all the chambers. For instance, let me just give you an example of in Cape Town. So if you look at all the websites, you will see that there's no chamber in Cape Town at the moment. But actually, today in Cape Town, there's 14 chambers. And so people just don't know where they are. We are the only people that keep that database, and it's associated with some of the commercial divers, etc. These things are mobile. Depending on the work that they do, these things move around. The same in Limpopo. So there are a few diving companies that are working on some of the dams. And when they are working on that dam, that chamber would be there at that time. And so the commercial companies let us also know where they are. And so I can say, yes, we have a chamber in Limpopo today there, but tomorrow it will be somewhere else. So do we have chambers in Limpopo? Yes. Today it's here, tomorrow it will be in a different place. So the bottom line is one needs to phone the Divers Alert Network if you want to know where the chambers are.
Thanks. And then I want to know if ground support is considered more ideal for such patients.
It's really dependent on the case. So the recompression is obviously the ultimate treatment for those cases, so that you can redissolve the bubbles and that you can get the oxygen to the tissues that are hypoxic and critical. But if a person is totally unstable, then you don't want the person to die in a chamber. So some patients first need to be stabilized and so forth. And the chamber basically functions like a theater. So a person might have a gunshot wound and they say, we need to get the person to theater, And the anesthetist will say, no, first resuscitate, get the patient stable. Otherwise, he's just going to die on the table. And the same with hyperbaric chamber. Sometimes you will first make sure the person is intubated, make sure that he's got all the IV lines and central lines and things in place before you will put him in the chamber. Otherwise, he's just going to die in the chamber, because once the person is in the chamber and the doors are closed and it's pressurized, to lock in something like adrenaline or any of your resuscitation drugs is not possible. It takes a long time. You cannot defibrillate inside the chambers because of the sparks and the fire risk and the high oxygen contents and so forth. So you would first do those resuscitations, and then once the person is stable, you will then only do those interventions. So sometimes we would say go to the closest emergency room, and other times we would say go directly to the chamber. So what is best, ground or air? So which one is the quickest? So we look at what the best option is for that specific case, and we individualize. So sometimes it's air, sometimes it's ground. Sometimes the pressure difference is an issue. So we do evacuations on a daily basis. So there's obviously a lot of doctors that works around the world on these cases. So if you just look at me as an individual, and serious decompression sickness cases that really need emergency evacuations, I deal with about 3 such cases every day. So we've got the experience. We know how to deal with these cases. In South Africa, we deal with probably around, I would say, 1 case a week. So during summer months, they tend to be a bit more, winter a bit less. And we get about 1 to 2 calls per day, I would say, more or less.
Airway and oxygenation, is intubation a priority on post-rescue scenarios?
Sorry, you broke up a little bit there. Could you just repeat the question?
In terms of airway and oxygenation, is intubation a priority on post-rescue scenarios?
So the same principles apply. It's no different than any other environment. So we don't change the normal emergency protocols. The only difference is, remember, with Boyle's law, the change in volume, and that obviously would apply to the ET cuff. So if that person is going to fly, then you might lose the seal or the expansion of that cuff. Or if they go in the chamber and you compress the person, you're going to lose the seal of the ET cuff. So we would use something that would not be affected by that, or you would then inflate the ET cuff with saline or sterile water or something like that. So some minor differences there, but we intubate a person if you want or you need to protect the airway. But if they are totally conscious and all of that, then we don't. Then we just put them in the chamber because they're still fully conscious, and they can hold the oxygen mask on their own, and we just strap it to their head, and they breathe the oxygen in that manner.
Thank you. Is there any other questions, or have we missed anyone's questions in the chat? Nobody else has any questions, then I think that's it for today. Thank you to Dr. Meintjes for giving us your time and presenting. Thank you to everyone for joining Coffee and Cases once again. And a big thank you to Stat Medical for sponsoring this. We'll post the link for registration and the word for the day in the chat now. The word for the day will be dive in emergencies.
Thanks, everyone.
Thank you. Bye.
Thank you,
Thank
Dr.
you.
Meintjes.
Thank you, doctor. Thank you.